people don't understand. So for those of you that don't know me, I'm very proud to say I'm a very religious person, deeply spiritual, believe in God, very religious. And we actually have a video coming out on how you can provide people fertility service religiously. But for vitamin K, people keep saying that to say that babies need vitamin K is questioning God's design, and God doesn't make mistakes. So can we just establish very quickly that I fully agree that God doesn't make mistakes. However, God has nothing to do with ongoing biology. Like, he's a busy guy. He's not concerned with the biological setup that he created, which includes mutations and evolutionary changes and babies born sick or stillborn or with cancer or with all their organs turned around because it's called situs inversus, or with parts missing or extra chromosomes or missing chromosomes, or a host of various possibilities, none of which are normal, and all of which are there right from birth for the baby. So this idea that babies are perfect and God designed it that way is just so incredibly, insanely silly. I can't understand why people keep arguing this. I'm not questioning God. I would never do that. That's blasphemy. This isn't about questioning God. It's about biology, people. And biology has nothing to do with God. God did not make human beings perfect. That's why we have medicine. Otherwise, we wouldn't need medicine. God is perfect. Human beings are not. Say it with me now. God is perfect. Human beings are not, including babies. They are imperfect. They need food. They need diaper changes. They need protection. They need warmth. They need energy supply. Some of them need sunshine. Some of them are born, unfortunately, with jaundice. And if we don't treat the jaundice, they can get severe brain damage. This all has to do with just plain old biology. So for people that keep sitting there and spewing all this crazy nonsense about God not making mistakes, no one's questioning God. I would never do that. I like to, end up in the happy place, not in the hot, fiery place. I'm not questioning God. I'm questioning this very silly concept that babies automatically are born perfect because of God. Babies aren't born perfect because of God. He didn't design it that way. You may not like that, but that's just biological reality. And it has nothing to do with the, consumables and the exposures and the toxins. Like, genetic abnormalities have nothing to do with that. That can just be maternal and paternal age. At the end of the day, what's really important for people to understand is that there is no question that babies are born imperfect. And whether you want to hear that or not, that's up to you. But please stop coming on my channel and saying that babies are born perfect. There's no baby that's born perfect. Like, that's just genetics, and you can't escape that. Every person, every child has problems. Everybody has something. So even if you have no genetic abnormalities, you're going to have something there at some level, whether it's enzymatic or protein or whatever. So please stop saying babies are perfect and it was God's design. God didn't design babies to be perfect. That's how humanity is designed. We change, and that's how we adapt. And so please stop saying that. I beg you, because it's just so silly. And I have to constantly repeat to people, God is perfect. Babies aren't, like, over and over again. I think I said it 5 times today alone. So with no further ado, having ranted about that and watching Tarek clean the camera on my cell phone doing TikTok with his shirt, we can now move on and talk about anything you guys want to talk about. So if you have questions about fertility or vitamin K or vaccinations, to the best of my ability, please don't hesitate. Feel free to ask. We will do our best to answer as many questions as we can. And a huge shout out to my wife, who drove all the way to Kingston to see our son for Thanksgiving. Honey, I love you. I'm glad you're on your way back home. And I'm looking forward to seeing you.
Can I say that we started something on this right now? There's a new trend in the comments.
Okay.
It's a great trend. It's a fantastic trend.
Okay.
I think you'll also appreciate the trend. But the trend is, why don't I just read it to you? Dear Royal King T and Dr. V.
Here I am thinking like this is something meaningful for us.
Yeah, that's pretty meaningful. This is great. This is fantastic.
Royal
And
King.
just so you know,
Yeah.
it's not just one instance
It's several
of kings
times.
being mentioned here. Kings.
Yeah. I did feed us like kings.
Yes, we ate well.
We ate well.
We ate well.
Yeah.
We
Shout
ate well.
out to Mazar. By the way, this show is not sponsored, so I can say anything I want about anybody because I'm not getting paid for it. But we had dinner from Mazar tonight, and it was actually spectacular. It was great Lebanese food. I'm usually a diehard kebabji fan for you Windsorites, but Mazar was really, it was very, very good. Some very excellent tastes in there. And the fresh little hot pita buns.
Can't go wrong with
Yeah,
the hot
you
buns.
can't go wrong with that. It was good. All right, fire away. Dear Kings.
Dear Kings, absolutely. Dear Kings, yeah.
Royal.
Dear Royal King T and Dr. V.
Yeah, I am not a royal king. That's Tarek, apparently.
But no,
Yeah.
but in this
I'm
one, you
gonna
were
get you a
included.
crown for
You were
next time.
included in this. Dear Royal King T and Dr. V. You're
Yeah.
part of the symbiosis of it all. I'm 39 and have one euploid embryo.
Okay.
After 4 retrievals, going to do my 3rd month of endo suppression before an FET.
Yeah.
Would you recommend endo excision 2?
Yes.
Is there PubMed literature to support?
There's no PubMed literature that looks at doing suppression and surgery, but we know separately they're each beneficial. So it would make sense to do both. On top of that, you never get everything when you do the surgery. So, and you certainly don't get everything when you do suppression. So there's no question that you are going to do better with the combination than you are with one alone. In particular, if you have an endometrioma, because the endometriomas 100% are going to cause a huge amount of inflammation that suppression simply will not overcome. We are working on a new technique for treatment of endometriomas. I'm hoping we'll be ready to do that in the new year. I may have to go somewhere to watch how they do it, but I'm setting that up. And so it's a very simple technique. I just need to learn about the ins and outs of what they're doing and how they're doing it. And if we get that, it will be a way of permanently treating endometriomas without surgery. And yes, you did hear that right, but it's not ready yet. Likely in the new year.
How many days before an egg retrieval do you recommend starting melatonin, or do you recommend taking it all year round for egg quality? And at what dosage do you recommend?
The study that we reviewed several years back, if I remember correctly, started at least 1 month in advance, and they used 3 milligrams. So that's what we do.
Before egg retrieval, what size should the biggest follicles be on the day you trigger?
Well, that depends, because sometimes we'll sacrifice one follicle to get all the other ones that we are trying to go after. So it's not always easy, like we just choose one follicle size and then we chase that. So occasionally we will allow a follicle to grow to 22, 23. I have one today where they said it was 25. I don't actually believe the measurement's correct because it's being measured elsewhere, but I'm letting that one go because we have a whole cohort of other ones that are 17, 18, 19, and those are the ones I want. So typically you want to trigger when your follicles are between like sort of 18 and 20 millimeters, but there are times where we allow it to go a little bit higher or lower in order to facilitate having the most number of eggs ready at the same time.
Dr. V, hi. And T. I almost don't know why I read this.
Well, you know,
but I do know why.
Yeah.
I do actually know why. But for the sake of the show, I'm having some fun here. Had 4 follicles mature.
Yeah.
But only 1 egg retrieved despite follicular flushing.
Oh.
Worst cycle yet. Why weren't more eggs retrieved? Dr. V?
I mean, I would ask how many times they flushed. We usually go anywhere from 9 to 12 times before we give up. So that would be my first thing. The second thing is you didn't trigger with enough or didn't double trigger, which we do routinely. And then the other possibility is what they saw were not actual follicles. They were either cysts or para-ovarian instead of ovarian. So I would need to know more details about you and your case.
So this questioner here did not intend to insult me.
Uh-oh.
However,
they did.
Uh-oh. But
well, that's not a good start.
But not intentionally. Let me read it to you and you tell me why I have a problem with this. Hello, Dr. V and Assistant T.
Yes.
You see what happened there? You see what happened?
Yeah. I love the fact that you are still brave enough to read that.
I'm here for the people.
Yeah.
I'm here for the people.
Yeah. All the way from king demoted down to court jester.
Yeah, that's basically what, see, you got it. I'm not making this up. You got
All
it.
right, yeah.
What are the odds of untested blastocyst embryos becoming a live birth?
Well, that depends on 100 different factors. Those, people ask these crystal ball questions from us all the time, and I love them, but like, I can't answer that. It's impossible to answer that. It could be 5% if you're 48 or 50 years old, or it could be, 80% if you're 32 years old. So there's no way for me to answer that question. It would depend on your BMI. It would depend on the shape of your uterus. It would depend on sperm quality, your partner's BMI, your habits, his habits. Did anyone smoke, drink, use marijuana? It would depend on number of previous failures. It would depend on embryo grade, date of the embryo. Is it day 5, day 6, day 7? Like, there's so many details that go into those calculations that I need to know about before I can advise you at all.
We'll go into the wonderful world of TikTok here. TikTokers have been waiting.
Sure.
TikTokers need to give us some likes.
Some likes.
Yeah, because it's pretty minimal right now.
Although we've been growing steadily on TikTok.
Don't get me wrong.
Not as fast as on our other platforms.
That's what we need. Yeah. Likes on here. See.
It's all going now.
See
yeah,
this here?
I see that.
This is called hearts. This is not. I want to see that all the time.
Yeah, we need the hearts nonstop.
Then I'll just stay on this platform.
The other thing we need people to share their stories, because the more you share, the more viral they get. So please share the stories. If you like the stories, please share them. Save them, share them.
Let's have some fun.
Comment. Yeah.
Dr. V, thoughts on embryo glue?
Yeah, embryo glue. Most of the studies on embryo glue show that it's beneficial. It's certainly never been shown to be harmful, and it's actually remarkably inexpensive for the fertility clinic. So way back when we first started, we were charging for embryo glue because that's what everybody else was doing. And then one day I went to my embryologist, my lab director, and I said, how expensive is this? And then when she told me, I was like, we should just include that in the cost. So we don't charge people for embryo glue, and we use it for every single case. So for us, everyone's getting embryo glue.
So for the individual that referred to me as your assistant, which in any case is a great honor. May I be quite transparent here? It's a great honor.
Yeah.
He says, yes, I wanted a reaction. So now everyone's in on it. Everyone's aware. Everyone's aware.
That's good. That's creative. They got you.
They got me. They still got me. Yeah, absolutely. Yeah, it worked. Congratulations, buddy. I'm never gonna pick this guy again. No, I'm joking. Okay. Oh wow. You want to talk about getting my attention? Tariq! Exclamation mark. My legs have been hurting daily since July. Suspected endo. Is there anything I can do or take to alleviate the pain while waiting for surgery?
Yeah, loads of medications. Vizan, Lupron with Adbac, or Alyssa with Adbac, Myfembry, even the birth control pill. There's analgesia, acupuncture, traditional Chinese medicine, yoga can help. There's a million things you could do. Lots of supplements, NAC, curcumin, resveratrol, ALA, coenzyme Q10. I got a whole litany of things you could try. So talk to your doctor and they'll help you out.
IVF for severe oligospermia, less than 200,000.
Oh,
First cycle made 3 euploids,
Wow, that's awesome, actually.
2 failed transfers,
Yeah,
possible endo.
yeah.
Is testicular sperm indicated?
Um, no, not if you did that well. I mean, if you made 3 euploids, why would you need testicular sperm? Testicular sperm in studies of extracted sperm has only ever been shown to be beneficial in cases where there was very poor blastocyst development or fertilization. So fertilization first, obviously, and then blastocyst development. In those cases, it's probably worth considering. But in every other case, there's no benefit, or at least no proven benefit, to using testicular extracted sperm. The only other time is in cases of very high DNA fragmentation. And there are easy ways to get around DNA fragmentation now. And we just created 2 new videos, which are the long forms, which will be going on our YouTube channel. One on hyperbaric oxygen therapy, which actually looks like it's remarkably promising for a variety of fertility issues, including sperm. And we made another video that will also be coming out on NAD+, and it too may be beneficial for sperm. So there's a lot coming out in the sperm world that will be helpful for guys that are struggling, including some research we're going to be doing very shortly. So excited about that too.
Even on TikTok, the trend has continued. Kings!
You really like that.
Thoughts on adding a GLP-1 during endo lupron suppression for help inflammation for FET?
Interesting, but no data to demonstrate that that is actually something you should do. So love the idea. We know that the GLP-1s are great at being anti-inflammatory. They're very good at reestablishing a healthy microbiome, which is also really beneficial. But I'm not aware of any evidence that says that it's beneficial in conjunction with endometriosis treatments. Not that I've seen. I will happily look it up because I've got my little source here, but
we just got 16 or 20 pumpkins from somebody on TikTok. So I think I'll just read their question.
Okay, read the question.
20 pumpkins.
Yeah.
That seems very generous. Thank you for these pumpkins. After 2 PGT losses, I'm now doing IVIG. NK cells came back at 15. Am I on the right path?
Well, IVIG is very strong for NK cells, but I guess I'd be asking, like, why did you have the loss? Have you looked at the shape of your uterus? Have you looked at sperm DNA fragmentation? Have you looked at a comprehensive immune profile? Did you look at your cytokines, your KIR, your LADs, all of that stuff? And then I would want to know about whether or not you looked at your microbiome. So looking at failed or losses of euploid embryos requires more than just, hey, what are my NK cells at? So make sure you're with someone that really knows what they're doing. Otherwise, you can miss things pretty easily.
At what point in the pregnancy would you stop taking progesterone? Quinone specifically.
So for vaginal cases, like vaginal progesterone, we don't stop. We actually continue the whole way until 36 weeks because it reduces your risk of preterm labor. For patients who are dealing with injectable progesterone, our practice stops around 12 weeks, and then we continue the vaginal. But remember, our patients are getting both the whole time. Yeah.
Can you explain the number of days of progesterone in a frozen embryo transfer? Example, day 5 versus day 6.
What part of that did they want me to discuss?
The number of days of progesterone.
Oh, yeah. So there's a study we reviewed on the show, which I've shared with occasional colleagues who have asked for it, which showed that day 5 embryos should be transferred after 5 days and day 6 after 6 days of progesterone, because there was a higher miscarriage rate if you transferred a day 6 embryo after only 5 days of progesterone. So we use 6 days for those ones. I just looked up GLP-1 and endo. And interestingly, there is lower levels of GLP-1 in the fluid of your pelvis if you are an endometriosis patient. So there may be a GLP-1 role. But that's basically all they know about it so far. There has not been any direct research to look at other things.
On the
Yeah.
subject of GLPs, when to stop GLP before an FET?
6 to 8 weeks.
Hi, POI 35,
Mhm.
one follicle, AMH 0.01. Any chance to conceive? Any tips?
Yeah, there's always a chance. It's going to be difficult, and depending on who you believe with regards to does low ovarian reserve uh, associate with or correlate with higher risks of genetically abnormal eggs, you may or may not want to continue down that path. So some people believe that if you have a very low AMH, you also have higher risks that the eggs that are still there are genetically not normal eggs. Other people say, no, that's not the case. So it's a bit of a risk that you're taking when you enter into that whole realm of low AMH. Any tips? I mean, I would do everything you could to keep your ovaries strong. Eat healthy, don't smoke, don't drink, don't use drugs. Have frequent intercourse, make sure your partner's doing all the healthy things as well. Take the NAD plus, it may be beneficial. Make sure that you're on lots of supplements, all the things that we know are helpful: vitamin D, iron, your omega 3s, your melatonins, your coenzyme Q10. Like there's lots of natural things you could do. Talk to a traditional Chinese medicine specialist about acupuncture, or someone in Ayurvedic medicine about yoga, or even just a yoga instructor. There are lots of natural, sort of relatively easy things you can try to do. But I mean, overall, it's a difficult position to be in. I just came across an article right before the show, actually, that said that scientists have figured out how to make infertile mice ovulate again. Um, I didn't get a chance to read all of it or figure out how they've done it, but we're getting better and better with the science and the research, and people will figure out some of these questions, but we're a while away. And in case you didn't hear about it recently, um, in a highly inefficient procedure, very inefficient, scientists were able to take skin cells and literally make egg cells out of them by forcing them to lose half of their DNA content, which makes them what we call haploid. And then you can mix them with sperm and fertilize. And they actually successfully fertilized eggs. The problem is it's incredibly inefficient and it'll take innumerable tries, but it's coming. And once we can do that, it won't matter how old you are, you'll still have a chance, because there's an endless supply of skin cells. So you just keep doing it over and over and over again. It's very cool technology, but it's incredibly inefficient right now. So that's what they'll be working on next.
Dr. V, thoughts on adding omnitrope?
Yeah, I'm a big proponent of Omnitrope. We use it for almost all of our POI, DOR patients. So I think the data is very clear. I actually just looked it up again the other day. Someone in the UK had a doctor that didn't believe in it, so I had to send the meta-analyses. It's very clear. I mean, there's multiple meta-analyses demonstrating that it works. Even if you ask any AI, system, it'll tell you that the evidence is very supportive. So yeah, there's no question that human growth hormone works. It doesn't correlate yet directly with an increase in live birth, but they are seeing more eggs. They're seeing more mature eggs. They're seeing more blastocysts, better quality blastocysts. I think it's just a matter of numbers and time before we see more actual live birth data. But so far, there's lots of information showing that there are preliminary benefits without the full live birth picture.
Here's an interesting question, Dr. V. If I'm trying to bank embryos
Yeah.
as fast as possible,
Yeah.
how fast can I do egg retrievals after I finish one egg retrieval without compromising egg quality?
Depends on how strong your ovaries are. Like there are a lot of people that do duostim where they go back to back. So you'll do your follicular retrieval, you wait 5 days, you start your stim again, you do another retrieval. So that's as fast as you could do it. There's even some duostim papers that looked at 3 days intervals. So that might be even a little bit faster, but that's the fastest. Is there a harm in going back to back? No, not at all. You can go back to back. In fact, there are some studies that show that the meds kind of prime the ovaries to give you a better response. So it could actually be beneficial going fairly close together, if not right back to back.
Dr. V, I got this question 4 times.
Okay.
You ready for it?
I'm ready for it. Don't forget TikTok too.
Yeah, no, I got them. This is actually a TikTok question.
Oh, okay.
In TikTok, this question was asked 4 times.
Okay.
4 times.
4.
Dr. V, when are you going to open up your clinic in the US?
Oh. I don't know. This stuff is psycho difficult to run, guys. We are just about to hire our 69th and 70th employees. And then we probably need a couple more. It's like busy. It's really hard running this. Like, I love doing the medicine. I love helping people. I love operating. I love doing IVF. We do tons of research oriented things here. I like growing the business. I like thinking of new ideas. I like traveling to tell people about what we do. We like helping everybody. I love the social media stuff. I love answering people's questions and challenging some people. I like that too. But running the business, oh, it's freaking horrible. Like, it's genuinely horrible. I don't like running the business because I don't want to run a business. I just want to help people. So, if we can get it to the point where it's running without me needing to run it, which we're actually actively looking at very soon, having somebody else kind of run VRC and I get to just continue the medicine, I think we could look at a US clinic. Until then, I have some ideas about joining with someone that I really like and admire. So if that individual is interested in a collab, I would be willing to look at opening up with that person. I'm not going to spill any.
No bean spilling.
No beans spilled. Yeah. And for anybody from VRC who's watching, I don't have any immediate plans. Plus, they've put a moratorium on me doing anything new for 4 months because I was told I am not allowed to start anything new for 4 months just to give everybody a chance to catch up. My brain's one of those brains where, like, I think at 100 miles an hour kind of, and it's hard for people to keep up with that pace sometimes. And so everyone else wants organization and structure, which I fully appreciate. That's the right way to do things. But I'm more of a fly by the seat of my pants kind of guy, and they're more like organization and structure. So my team has taught me the value of the fact that even if I'm thinking it at 100 miles an hour, we can't implement it at 100 miles per hour, and that it's important to implement it correctly. So I'm listening to my team. I appreciate and respect my team. I hear them. I see you. We're going to do it the right way, not the fast way.
Hey,
that didn't go anywhere, man.
Because I read it in my mind first, right?
Yeah.
Like as people normally do, and then I don't understand what he tried to say, and I couldn't figure out how to say it the way he wanted to say it. So I think I'm just going to read it.
Okay, and then I got to make sense out of it.
You got to make it make sense.
All right.
Hey, I had 100 IU of Proveris last month.
I had 100 units of Proveris last month. Did one of the cameras just shut off?
Yeah, it's okay. It's not mine. It's mine. Yeah.
Okay. Yeah.
5 follicles made.
Okay.
Doctor wouldn't do IUI.
Okay.
Period is now 5 days late.
Okay.
Is this normal on that medication? Times passing me by.
No.
I'm 45.
You probably are pregnant because you had 5 follicles develop. So go get a preg test. That's not normal on that medication. Not normal at all. So go get checked out. That would be important. Yeah. That's okay.
You're going to go into it a little bit.
No, I mean, 5 follicles, that's a lot. I don't blame him for not wanting to do an IUI, but did he tell you not to have sex? Or did you not listen? Because when we have someone like that and they don't want to drain the extra follicles, we tell them you cannot have sex or else you're going to turn into octomom.
Oh, really? That's what happens, right?
Or
something like that.
Quintuple mom.
Yeah. Stage 3-4 endo. Just did 2 months suppression. Doctor wants me to start estrogen 3 times a day, 2 weeks before transfer. I kind of laughed when I read it. I don't mean to be disrespectful. It's just, I
Well,
know.
hopefully you saw the Tom Cruise little segment from Mission Impossible that I included in my Instagram the other day, which is exactly on this topic. Um, I always describe this because I think it's the best analogy as turning the light off and turning the light on. So if you need the lights off to make your embryo transfer work, which is like low estrogen, right? Because you want the endo to be quiet. So lights off, put the endo to sleep. It's in rockabye baby mode. It's quiet. It's happy. It's in slumber. It's not attacking anything. Then you need to keep the estrogen levels low. And the minute you give someone estrogen, not only are you undoing the sheer ungodly torture of months of Lupron and plus letrozole if they did it correctly, but you're inflaming the endo. You literally turned the sleeping baby into the Tasmanian devil and unleashed it in the endometrium. It makes zero sense. It's just so biologically incorrect. I can't understand why anybody would think that that makes any sense. Like it's bonkers. It makes zero sense. It's not even plausible.
I think you need to go into the idea of why this shouldn't be done, because this question happens a lot, right? Like it comes up often, and I think it's important that let's address it. Let's address why you cannot do an estrogen protocol. That's what they call it, right? Estrogen protocol,
hormone replacement.
Replacement when you have endo. Like this because let this video be the reference video.
Sure.
Just go at it.
Okay. So
rant it.
Okay, rant it.
Rant it.
So endometriosis is an estrogen dependent disease. We know that the cells use estrogen to help grow and spread and wreak havoc. We know that they are not particularly immune sensitive, meaning your immune system is not good at recognizing them or eliminating the cells. So now you've taken this population of cells that shouldn't be where they are. You're happily feeding them crazy amounts of rocket fuel for cell growth. And then you've got a dysregulated immune system that can't keep them in check. Think riot with more and more people pouring into the crowd, and your police are completely incapable of managing the crowd. And then you start handing out Red Bull. Okay, like that's what endo and estrogen is. It makes no sense. If you want your crowd to quiet down, if you need your crowd to like settle, you don't give them Red Bull. Like that just makes no sense. Estrogen is Red Bull for endometriosis. It makes absolutely zero sense. And anybody who thinks that that makes sense just absolutely does not understand endometriosis, which is very clearly an estrogen dependent disease. Now, you get the people out there that think they're experts, which is kind of humorous sometimes, who say, well, the cells make their own estrogen. Yes, endometriosis cells can make their own estrogen, but it's not the same as force feeding it 6 to 12 milligrams a day of estradiol. That the endometriosis cells then just get to have this luxurious milk bath in, and they're soaking it in, right? Because they're going crazy growing from all the estrogen that you're putting in front of them. It's like a feast. It's like party time. Let's go crazy. You can't give someone with endometriosis estrogen and expect a good outcome. Now, we do give our patients estrogen. Many of our endo patients, especially after the suppression protocol, need a little bit of estrogen to grow their lining. But we cap it at certain thresholds. And if we can't get it to work, we just stop and wait for the next month and start again, and they do perfectly fine. So I'm not saying completely eliminate the estrogen, because sometimes you have to give patients a little bit, but not 2 milligrams 3 times a day. That's crazy. It's way too high a dose.
That was good.
Yeah.
I appreciate you.
Red Bull on the riot crowd.
That's good.
That was good.
Yeah. I'm 5 months postpartum.
Is your camera dead?
No, I'm back.
Oh, but you're not on you.
No, Instagram's delayed. This is how much of a delay there is.
Is that much of a delay?
Oh, yeah.
Oh, I'm cheating.
Yeah.
I'm looking.
You're cheating. You're seeing yourself.
Totally
You don't know what
cheating.
usually happens. The angle.
Yeah.
Yeah.
All
Here
right.
we go. Also, sorry, where was that? Yeah, I am 5 months postpartum,
Okay.
and my PMDD is terrible.
Okay.
Would the IUD help me?
No, it'll make it way worse. PMDD is premenstrual dysphoric disorder. So basically, when you are very unhappy prior to your period. Severe moodiness and mood instability. No, the IUD will likely make you worse. That would be a poor choice for you. You should be on a estrogen, progesterone, birth control pill, as long as it's not contraindicated in your case. Please talk to your physician. They can find you something. Your alternative is to take antidepressants. SSRIs are useful for this condition, as are SNRIs. So that would be your best bet for sure.
Dr. V, I am on my third and final egg retrieval.
Oh, wow. Okay.
I want to make sure I do everything right.
Sure.
First cycle, 0 eggs, and second cycle, 8 eggs.
What?
My TSH is 3.16 and T4 9.
Okay.
Goal is TSH less than 2.5.
Right.
Should I postpone cycle
Yes.
to get this TSH better?
Yes, you should. It'll optimize your egg response and your ovarian response. You should look at all the supplements you need. You need to figure out why you got 0 eggs the first time. There's a lot to unpack there. Maybe DM me and I'll help you. But there's a lot you should do there. That's not a rush into another cycle situation at all.
Dr. V, I want to have babies and I don't know where to start. I've had 2 losses, 34 years old.
Oh gosh, I'm so sorry. Well, start with seeing a fertility specialist. That's where you start with a comprehensive evaluation, looking at why you had the losses. And don't jump into IVF just because they tell you need IVF, because it's very likely you don't need IVF. So first, figure out what's wrong, then address what's wrong. And it may not be you, it could be your partner. And then once you've addressed what's wrong, if you're still having trouble, then you start figuring out, do I need other treatments or approaches? But until you've figured out what's wrong, don't do anything. So see a qualified fertility specialist that specializes in recurrent pregnancy loss or recurrent miscarriages, and make sure they're doing the right workup for you. So reproductive immunologists or, a qualified fertility specialist who's good at doing the recurrent miscarriage and pregnancy losses. We obviously specialize in that quite a bit. I'd say we're probably more advanced than anyone is because we are even doing the whole genome sequencing for certain patients now. So someone like us or a reproductive immunologist, there's different people you can approach, but there's a lot of different options.
We are trying to start IVF.
Okay.
Not sure if I should pay for PGTA. I'm 38.
100% you should pay for PGTA. At 38, somewhere between 75 to 80% of your embryos are going to be genetically not normal. It's important to know which ones those are so that you're not wasting time taking lots of medications, shooting injections into your buttock, which is painful as hell, and having to go through the stress only to find out it didn't work without knowing that those embryos never would have worked because they were genetically abnormal. So there is no question at that age that it is beneficial. And so I would absolutely encourage you to do PGT if you're 38. Talk to your own doctor, of course, but I'd say the data is very clear at that age that you should do it. And it's cost effective as well.
Hello, amazing doctors. Almost 10 weeks pregnant, previous MMC at 10 weeks.
Okay.
Symptoms are fluctuating a lot.
Okay.
And are milder than before. Trying not to panic, but is this normal?
Your symptoms do get milder as the pregnancy goes on, so it is very normal. But if you're panicked, which is totally understandable, go for an ultrasound. Talk to your doctor and get a scan. Right? We're there to help you, so get a scan. Yeah.
Egg retrieval at 39.
Yeah.
With 225 gonal, 75 menopause.
Okay. Reasonable.
Hot 28 eggs and 17 mature.
Okay.
BMI greater than 33.
Okay.
Should I go lower dose next round for better quality and maturity? And can growth hormone help? Thanks, Dr. V.
Growth hormone can help in maturity. I would need to know how long you stimulated for. Your dose wasn't particularly high. I would maybe even out the menopause to gonal F, so like 150, 150, because you did a total of 300. But I wouldn't necessarily focus on just lower dose. The other thing you should do if you want to improve your egg quality is do your best to bring your BMI down. Bringing your BMI down will have much more of an impact than altering your dose will. Hugely, different and very significant improvement in egg quality simply by getting your BMI even under 30.
After 2 PGT losses, I'm now doing IVIG NK cells. We did that?
Yeah.
For context to my previous comment on PGTA, I'm 38 with PCOS.
Yeah,
same,
definitely.
Right?
Yeah, we did those.
Had 2 kids at 26 and 27, want to have a baby at 40. Thoughts?
Had 2 kids at 26 and 27, want to have a baby at 40?
Mm-hmm.
Yeah, have a baby. I'm not sure. Well, I'm not sure what I'm supposed to say there. Have a baby. I mean, yeah, of course. There's no reason why you can't. Risks of having a baby at 40, preeclampsia, diabetes, some heart strain, especially if you're not like super healthy. But aside from that, go ahead, have a baby. If you need help to have a baby, that's a different question.
4 BC and 3 BC embryos with your clinic. How do you feel about these gradings?
They're not ideal, but they're still very usable, and we have lots of success with BC graded embryos. So would I prefer they be BB or AB or BA or AA, whatever? Yes, of course. Who wouldn't? But am I okay transferring BCs all day, every day? Not a problem.
All day, every day. I like that. I like this. King T and Dr. V. 42 years old.
Okay.
Secondary infertility.
Sure.
2 failed IVF cycles.
Oh.
My second opinion with you, endo and dysbiosis, recent POS pregnancy test. Any recommendation?
Progesterone, baby aspirin, lots of supplements. Stay away from everything bad. Keep your weight down. That's the best you can do. She got pregnant after we did our consult. Cool. Congratulations.
King Tarek and the amazing Dr. V. I love it when it's like back to back like that. It's just so good. I tell you, I leave the show feeling so great. I open the door at home.
And the king is dethroned.
The king, he doesn't stand a chance.
Yeah, the king is dethroned.
Just with you guys. You guys are my love. Yeah. I love you all, really.
Your crown is gone. That's and you're right back to
this could be like like therapy for me, this show. This should be for everyone, therapy.
Yeah. In fairness, I think all of us get that a little bit.
Everyone's common here, right? Everyone's enjoying it.
I go home and I'm no one. Yeah.
Welcome to my life.
Yeah. My kids hate the fact that their friends watch me.
Oh yeah, sure. Yeah, why not?
It drives them nuts. They're like, Dad, my friends watch you. Okay. What am I supposed to do?
What can we do? People want to know things. So I'll read it again because it's so great. King Tarek and the amazing Dr. V. You have said the new IVM protocol can help older patients.
Yes.
Please explain how so and what mechanisms help older patients.
So the idea behind IVM for older patients came from a combination of 2 different strategies, one of which I can't really talk about because it's proprietary to what we're doing, but I'll give you the other. I'll give you vague details about it. So on the one hand, there is a lovely gentleman whose practice involves almost entirely older women. And when I say older, the mean age for his practice is 43. So he is truly dealing with older women. And so he needed to come up with strategies to maximize egg and embryo quality for those women. What he did was he did a lot of research and he realized that the oxygen tension or concentration in the ovaries as you age declines. And so his theory was, why don't we get the eggs out earlier and put them in the lab and mature them in the lab, and then we can give them higher concentrations of oxygen, and maybe we'll actually improve the, fertilization, blastulation, blastocyst development, and who knows, maybe even the genetics, right? So this was his theory. And he has published one study, which admittedly is very weak. It's not a great study. But he has published one study which showed kind of promising results. And certainly the basic science of what he's saying is absolutely there. The problem with his model was that essentially you needed to do part of a stim and then retrieve the eggs and then mature them after they were kind of partially mature and they were close to being fully mature. And we know that those actually don't work well at all. That's like rescue IVM. And rescue IVM is garbage. I mean, we all know it doesn't work well. It's got like a 10% success rate. So rescue IVM doesn't make sense. But what if we could take eggs with no stimulation? So I am talking about zero medication, folks. Retrieve them very early on, like when they're still germinal vesicles, the starting point for the eggs, and mature them in the lab into mature eggs, and then fertilize them and see if we get good embryos. So the interesting thing with this, and sorry, I have something in my eye, which is driving me crazy. The interesting thing with this is that somebody who shall remain nameless for privacy reasons and an NDA figured out a way to mature very immature eggs better than anyone was doing it previously. And so we had to do a little bit of travel to some very, very, very far off places to figure out how to do this. But we now know how to do it. And we can take germinal vesicle level eggs and mature them in a normal oxygen environment into mature eggs. So has it ever been done before? No, we're literally going to be the first in the world to do it. How long is it going to take? We are anticipating a November 1st start date now. Fingers crossed and everything goes well. And it's basically like get into an experimental protocol if you're willing to take the risk and pay for it to see if this will work for you. Does it work? Nobody knows. It's never been done before. But the theory is 100% ironclad. It should work and will 100% revolutionize fertility care for older women if it does work. The other thing about this that's critical is there is a company that we are working with which has figured out how to make women whose eggs are older produce genetically normal embryos instead of genetically abnormal embryos. And the way they do it is by maturing the eggs in vitro. So we're going to have to move towards that model for those patients if that's up and coming. And because that's up and coming, it's a few years away. I want to be poised to be the world leader for it. So we're already starting the groundwork for that, so that when it hits and we're doing research with that company, we'll take the world by storm. Like it'll change everything because we can massively change the outcomes by getting you genetically normal embryos. It's not ready yet, so please don't call and ask for it. It's not ready yet. It's not commercially available yet. It's still in research format and it's never also been tried before. But their animal data is very convincing. So it's up and coming. We're part of it. We want to be the first to bring it out to the world when it's available.
Thank you both, your majesties, for this honorable, smart, funny, knowledgeable talk. That's right. You know what?
That's pretty good.
You're going to go home today and you're going to say, you know what? Somewhere in the world, I was a king today.
I was a king today.
You were a king today. Yeah, see?
Certainly not in my home.
No.
You know who's king in my home? The freaking cats.
Yeah,
the cats are king.
All pets are the king. Absolutely.
The pets are king. Wendy gives the cats more attention than I've ever gotten in my life. All I hear is, how's my mithril? How's my mithril?
I can definitely echo exactly that sentiment.
Yeah,
I can relate.
Yeah.
How can hyperbaric chambers help fertility in women?
Again, based on the low oxygen concentration, if you force more oxygen into the patient, you're going to do better. So there is animal level data that Tarek and I just reviewed yesterday in great detail when we were making videos.
It's a great video, by the way.
It is a good video. That shows very clearly that you're going to do potentially better from an AMH, intrafollicle count, blastocyst development, even pregnancy rates. Huge increase in pregnancy rates in this one study from 18 to 53%. It was a threefold increase in pregnancy rates. So this is like extremely, extremely powerful tool that might be available to help people. How powerful is it? I'm looking into buying a chamber, hyperbaric oxygen chamber that we would use on premises. I would have already purchased and distributed the home ones because you can get them portable, but they're not legal in Canada yet. So I'm going to start working with the company to get them in here and use them. So we're going to work on that. I love your smile. You're just like so happy looking for the ones that like stoke your ego.
You know, the problem is, as every good king, you know, tries to be fair to their people,
to their plebeians.
I won't even call them my subject. We're all equal here. You know, we're all equal. But there are some damn good intros that I feel deserve, but they're just so far down compared to the other people that, you know, even though you may have a weak intro, I sympathize, you know, but, you know, guys, do yourself a favor, write a good intro, and then I don't have to feel so tormented to ask this question. Now, again, this normally isn't an insult, this intro, but for where we are now in the show, it's become weak. For instance,
I just want to say that categorically, you guys have created a monster here. And I personally don't need you to call me king anything, please.
No. Call him king. He likes it. Don't worry. Hello, Dr. T and Dr. V.
Yeah.
And like I said, normally this is very good.
You've moved.
But I'm not a doctor anymore. I've become a monarch. Give me my throne. Let me enjoy life. I just went past it. So again, humbling myself to Dr. T.
Yeah, humbling yourself down with me and the other plebeians in the audience.
In the muck, right?
In the commoners.
With the common folk. What happens to an inconclusive PGT tested embryo?
You can still use it, right? You don't know, so you may as well use it. So there's a lot of different stages of embryo categorization from PGT. And the more we learn that some of them are very usable. Like, for example, a segmental aneuploid, full aneuploid, which has only a segmental abnormality, has a 24% chance of becoming a genetically normal baby. So there are many embryos you can still use.
Hi, doctors. 35 years old, AMH 34, normal semen analysis.
Woo!
Labeled unexplained infertility.
Yeah.
Failed IUIs.
Yeah.
Moving on to IVF.
Yeah.
PGT or no?
35 years old?
Mm.
Oh, yeah, absolutely. Especially with that AMH, you're going to have so many embryos. You want to know if they're normal or not. Absolutely do PGT. But keep in mind, if you have truly unexplained infertility, you may actually have endometriosis. So before you do anything, rule out endo. You may not need IVF.
Did I ask you a question today about Vizan?
No.
Kings. My doctor wants me on Vizan. Now I want you to notice what just happened here. This is very important for where the show has gone, evolutionary.
Okay.
We are now kings.
Yeah.
And people are being treated by their doctors. And they want our support. I just want you to see what happened.
I'm not a king. I'm happy being a
You
doctor.
are part of this king's pluralism
All
here.
right.
Want me on Vizan for 8 weeks before egg retrieval.
Sure.
I have deep endo, and I'm very skeptical about this due to getting less embryos. Thoughts on this?
There's one study that we reviewed on the show, I want to say about a year and a half, 2 years ago, which showed that Vizan prior to IVF stimulation is actually beneficial. So it can be done. I do suspect it will suppress you to some extent, but it does apparently enhance the outcomes. Now, I do believe some of that was because they were using fresh embryo transfers, and it's clearly going to improve your fresh embryo transfer success because you're suppressing the endo. But it's probably beneficial overall. So I would take a crack at it. I don't think it's going to harm you in any way.
Have you ever prescribed bromocriptine to your patients for egg embryo quality? A top fertility specialist in the UK is currently doing this for most of his patients.
No, I haven't. And unless your prolactin's elevated, what's the logic behind that? Someone's going to need to tell me. But I love learning new things. So let's look it up. Bromocriptine, oh, for the love of God, and IVF stimulation. I'm looking it up. Let's see. The bromocriptine, oh, here we go. Bromocriptine, blah, 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 reduce risk. Okay, that's not helpful. Here we go. The bromocriptine rebound method, where bromocriptine is given before gonadotropin stimulation and then stopped. Never heard of this before, so thank you for bringing this to our attention. Has been shown to improve IVF outcomes. Studies report higher rates of embryo cleavage, better embryo morphology, and increased pregnancy rates compared to standard protocols, especially in women with previous IVF failures or poor ovarian response. The improvement is likely linked to optimized prolactin levels during stimulation, which we check on every single patient. The comparison was the standard long protocol, which nobody uses anymore. So that's really tough to quantify because they're saying that their pregnancy rate is 42 to 56%. But I'd shoot myself if my pregnancy rate was 42 to 56%. So that's not helping me any. This is not getting me anything better than what I'm already getting. So I would approach this with an enormous amount of skepticism. So the studies, one's in English, from 1996, which looked at the rebound method compared to long protocol. It's literally 30 years old. That's insane. So that's number one. And then number two is not in English, so I can't tell you anything about that one. And then number three, nope. Okay, number six, I can tell you is not helpful because the title is Uso da bromocriptina asociado a hiperstimulacao ovariana. Yeah, I'm not even going to do any justice to that one. So that ain't happening. Yeah, 9:00. So no good data, team. I'll look at it to see if I can find something else. Here's another one from 1988. We're going backwards. So we need to look at this. Interesting. We could definitely run another randomized controlled trial on it. Maybe that's the way to do it. Anything else? One more TikTok question.
I'll give you a good one. I'll give you a good one because 3 people chimed in on this subject.
All right.
Dr. Victory. So, they obviously didn't.
Yeah, you
noticed excluded. That, right?
I feel you, buddy.
Okay.
I'm sorry.
As long as you understand.
I'll get you some Kleenex.
I appreciate it.
Yeah.
Dr. Victory.
Yeah.
You hear another endometriosis in IVF, but never really adenomyosis in IVF.
Yeah.
What are the chances of success with IVF if you have adenomyosis? And I would conclude that you should make this,
another video.
Yeah.
Adenomyosis definitely has negative impacts for patients that have that condition and are undergoing IVF. We know for sure that there are reduced implantation, there's higher risks of bleeding, there's higher risks of miscarriage. There is also an association between having adeno and having endo. So some of those patients are going to run into trouble with actually having endometriosis concurrently, which is obviously a huge problem. So in that scenario, it's really critical to make sure that the adeno is being addressed. So when we talk about our endo protocol, it's really an endo-adeno protocol, because if you have adeno, I'm treating you the same way. Should you go into an IVF cycle expecting the same level of success as someone that does not have adeno? No, you should not. Should somebody pay attention to your adeno and deal with it? Yes, they should. And is it reasonable to just skip it and try? No, of course not, because those embryos are precious and you should be doing something about your adeno before you go through your treatment. So with no further ado, we're
Very
going to close
lastly,
out the show.
couple questions. People are asking, how do I book a consult at your clinic?
info@drvictory.com, or call the clinic, or come to the Canadian Fertility Show this Saturday at the Harbour Castle Westin in Toronto. Please, please, please come, because we want to see you all there. You can catch me in person. You can grab me and I'll answer questions. I'm happy to go over things with folks. I'm in a panel. We have talks. If you're looking at third party, where you need egg donors, surrogates, we have loads for that. If you're part of the LGBTQ community, hugely valuable for those patients, because we have a whole panel dedicated for that as well. Marissa Thompson, who owns the Canadian Fertility Show, has gone to great lengths, and I've been a big supporter. I'm a platinum sponsor there. I really love for everybody to show up. So please come out to the Canadian Fertility Show this coming Saturday at the Harbour Castle Westin in Toronto. Please, please, please be there. Have a good night, everybody. Thank you for watching The Kings on Fertility Fact or Fiction. And we will see you next week, where we will blow your socks off talking about the impact of COVID on male sperm and how it impacts not the guy, but his offspring, because that's what's coming around the corner. So if you are an anti-vaxxer, I challenge you to come watch that show. Have a great night.